I record.
So we're going to talk about bones, how we form them, what's really in a bone. Now, keep in mind that when we talk about bones themselves, they're never ever static. Even if when we're sitting here, we're always building and remodeling. And when remodel, we mean we take apart some bone, right? Then we put it back together. So there's always either destruction and rebuilding. The extent of the destruction and rebuilding is going to be different depending on age, depending on how much nutrition you get, depending on also, right, your sex, as well as, I mean, the big one also is, age and any kind of diseases, right? So osteology is a study of bone. Have we ever kind of have anybody that's an osteologist? No. Usually we only go think about the bone when something is definitively wrong, whether you have a fracture or you have some kind of issue where you're not forming new bone or the bones are weak and you have osteoporosis. Now, the good news is for you guys that are much younger than me, you'll always have a little bit more bone deposition than you will have bone destruction. There's always a balance, though. So when we talk about the skeletal system composed of bones, the big one's cartilages and ligaments as well. Obviously, the skeletal system, we know it has to do with the bones. But in this chapter, we're going to talk about how cartilage and bones are related. There's a huge relationship because I've probably heard that, especially for your long bones. In your first trimester of life, all of our bones that are long bones, and a lot of our even like weird looking irregular bones, like your patella, like the sphenoid, a lot of those bones are going to be made by cartilage at first. So all the bone itself is cartilage. And then at about the second trimester, we start replacing that cartilage and then replace it with bone matter that we see now, right? And again, the areas where we never kind of replaced in utero, that becomes our epiphyseal growth plate. That becomes our articular cartilages that we see at the ends of the long bones. Now, ligaments and tendons, we kind of talked about previously. Ligaments hold bones together. Tendons attach muscle to bones. And we'll talk about why these tendons, especially, are so strong, right? Functions of skeletal system: support, holds up the body, supports muscles. Mandible and maxilla support our teeth. Protect. Obviously, we're going to protect the spinal cord. It's going to protect the vertebrae. It's going to protect the spinal cord. The skull is going to protect the brain. Your rib cage is going to protect your heart and lungs. The weird thing is, there's no real protection of your abdominal regions except muscle. That's it. Movement kind of makes sense, right? Most of the skeleton is about some kind of movement. The weird ones are the ones that we're going to see these last three. Electrolyte balance. Calcium and phosphate ions are going to be either banked and put into bone matter or removed. And I want you to think of the bone itself as a bank for calcium. So when you have enough calcium in your bloodstream, you're going to bank it and add more bone matter. When you don't have enough calcium in your bloodstream, what are you going to do? You're going to have to destroy more bone and take out those withdrawals of that calcium. So there's always that balance. Now, the good news is when you're young, premenopausal, women are protected by estrogen and progesterone. But if those same behaviors of a bad diet, not getting enough vitamin D, not getting enough calcium continues post-menopausal, we see women getting a lot of osteoporosis, right, immediately after. Another weird one is acid-base balance, right? We don't think about it, but calcium and phosphate ions. Phosphate's going to be important in forming phosphoric acid that we see for our body and our blood itself. And certain parts of the skeletal system are going to have red bone marrow. That red bone marrow is going to allow us to have this blood formation. Now, it's not found everywhere. In babies, it's found just about everywhere. But in us, as you get to be adults, all right, a lot of those areas that are active in babies starts to basically shut down. So then only certain areas will we have stem cells that will produce bone as well as produce red blood cells, white blood cells. All right. Bones and osteotissue. Bones is osteos tissue. It's a kind of connective tissue that has a lot of collagen, a lot of what we call those, proteoglycans, right? And on top of that, we add calcium phosphate to mineralize it, right? Making it much more dense, much more rigid, much tougher. Now, that mineralization or calcification is a hardening process of the bone. Indi- Individual bones consist of bone tissue, bone marrow, always going to have some kind of cartilage with it, some kind of adipose tissue, especially if it's a long bone. The shaft of the long bone is going to be filled with adipose tissue, nervous tissue, right? Kind of makes sense because when you break a bone, it's going to hurt. And some fibrous connective tissue outside or and inside of it. Again, the big one is that understand bone continuously remodels itself and interacts physiologically with all of the organ systems in our body. Now, we know this inherently because anybody's ever had braces before. If you've ever had braces in your teeth, right, when they are going to make a little kind of changes, right, they kind of tighten it a little bit. At first, you feel it, and it's really dramatic change that you feel. Then, with time, it kind of goes away that dramatic change. The reason is by tightening it or loosening it, you can move the teeth by adding more stress to the bone matter itself that's holding the teeth in place, or adding less stress or decreasing the stress, right? So we're going to talk about how we do this in a second. Whoops, right? But for the most part, understand that we're continuously adding and replacing, and it allows us to do a lot of things, right? Including shifting your teeth, including repair when we have a fracture. Contains lots of nerves and blood vessels, which attest to its sensitivity and metabolic activity. Now, we have different types of bones. The long bones are what we're actually, when you think of bones, you think of the long bones, right? The femur, the tibia, the humerus, the radius, those kind of bones. Those are certain types of bones. All right, usually we find it in the appendages. They're longer than wide. They usually are important because you have muscles working on it, causing you to move that limb. Short bones or are best seen as carpal bones and your tarsal bones. They're equal in length and width. They glide across one another in multiple directions, right? And flat bones. So flat bones usually protect some kind of soft organ. Ribs are a type of flat bone. So is the sternum, right? It's going to protect your internal organs that are incredibly important, like your right, like your heart, like your lungs. Now, flat bones will also be seen like your frontal bone, your parietal bone, right? It's going to protect some kind of very fragile type of organ system. Curved but wide and thin. Irregular bones are just weirdly shaped, right? They're your vertebrae, your sphenoid bone, your ethmoid bone. These are irregular and it's hard to categorize these. General features of bones, right? Usually, in terms of bones, we'll have two main types of bones: dense compact bone and spongy bone. Dense compact bone has an outer shell that has that tree ring-like consistency. Remember when we're looking at the microscope, right? What we saw in the microscope was actually a type of bone we call dense compact, where you have a central blood vessel in the middle, and then these cells kind of orient them around that central blood vessel. And once they're around the central blood vessel, they can receive nutrients from that central blood vessel. If you get enough nutrients into those cells, they start laying that bone matrix, the collagen, right? And then if there's enough, calcium phosphate, then we put a hydroxyapatite on that collagen, on those matrix material as well, the glycosaminoglycans that we add to it, the filling that we see in a, connective tissue. Again, right? That connective tissue without the calcium phosphate usually is very similar to cartilage. By adding the calcium phosphate, you harden it, make it more rigid, make it more dense. Usually the shaft region right here, that's the very kind of smooth external area that's a long aspect of the bone itself, right? Usually in those areas, you're worried about strength. So you're not going to have a lot of room for bone marrow. Usually the bone marrow that we think about are found at the ends or epiphysis, right? The medullary cavity is a space in the diaphysis or shaft of the long bones that contains bone marrow. Now, this is not the red bone marrow. This is yellow bone marrow, right? Just fat. Now, this is going to sound gross, but I know in some, I mean, if you've ever eaten a bone marrow before, right, it actually tastes pretty good. Now, bone marrow is basically when we take like a cow or a pig's bone and we kind of cut it in half. And there's this fatty area that's in that bone marrow that a lot of cooks, a lot of chefs, a lot of well-known chefs, right, consider that the payoff for any kind of meat, even. That this type of fat is really good. They'll actually spread it on some kind of brioche bread, right? And it put some salt on it. And it's actually a really expensive type of appetizer you see when you go to some of these steakhouses. All right. I know it's kind of weird talking about it. I'm just trying to make that connection so then you understand that when we're talking about the shaft region, this is fat, right, that we see inside of it. This is not the red bone marrow that we see with like a bone marrow transplant with stem cells. Now, the epiphyses are the very ends. So the shaft is in the middle. The epiphyses are the ends. So you have a distal end and a proximal end, right? The distal and proximal ends, well, they're going to need to grow at that end when the rest of our skeletal system grows during puberty. You guys have heard of the epiphyseal growth plate. Well, the epiphyseal growth plate is called the epiphyseal growth plate because it's at the ends of your bones. And it allows the ends of both sides of your bones to grow in length proportionally. So then we get taller. Now, that's all to do with this dense, compact bone. When we talk about spongy bone, right, this is different. This spongy bone is actually found usually inside the dense, compact bone. So when we talk about bones, bones are usually a combination. Externally, we see this thick, tough, dense, compact bone. Then inside, we see a little bit of spongy bone. This spongy bone, pretty durable, right? But not as strong as dense, compact. What makes a spongy bone important is because this is where we see the red bone marrow, right? Where we see stem cells that will produce red blood cells, stem cells that will produce white blood cells, right? Skeleton is 3/4 compact, 1/4 spongy by weight. Spongy bone is found at the ends of the long bones and in the middle area of nearly all other bones. All right. So there's a reason why most of you guys are going to be, some of you guys are really popular. You know your blood type, right? You go to the blood bank often and give blood. Almost none of us are bone marrow, right, donors, right? Why? Because in order to be a bone marrow donor, you actually have to find out if you're a match. And once you're a match, you actually have to harvest the bone marrow from you, right? And in order to do that, right, you have to break through the dense compact bone and drill into the spongy bone. So it is pretty painful to actually be a donor of this. And you have to be alive, obviously, right? Right. So most of us that are organ, donors, yeah, by the time that happens, we're not worried about any kind of, pain for the organ donation. But with bone marrow transplants and donation, it does hurt. Now, spongy bone again, right? Understand that this is usually the internal aspect of the bone, and this is where we see the red bone marrow, where stem cells are found. Those stem cells will turn into white blood cells and red blood cells, right? Articular cartilage, a layer of hyaline cartilage that covers the joint surface, usually where one bone meets another, allows the joints to move freely and relatively friction-free. Friction causes inflammation, which causes severe pain. All right. Usually that happens when we have a breakdown in the articular cartilage. So the ends of all of our long bones have articular cartilage. That articular cartilage covers the very ends. And then when the two bones are moving, Then you have cartilage in between, so then there's never bone-on-bone contact. Once the cartilage breaks down, now bone matter can touch other regions of the other bone is supposed to meet up to, and now everything wears down. Eventually, you have bone-on-bone contact on both sides, and that causes tremendous pain. All right, at that point, people are going to have a hard time walking, so their mobility will be severely decreased, which causes severe issues with their cardiovascular system. Right, so we need to be very careful. We need to start treating them, and then we need the bad part is this, right? With this degeneration that we see this, all of us will get it. There is no good treatment, right? There is no medicine we can give you that prevents it. There is no medicine that will kind of decrease the likelihood of you getting it or treating some of the underlying condition. We can't make new cartilage and then graft it on. It just doesn't take. So the thing is, the only treatment we have is some kind of arthroplasty, a knee replacement, right? A hip replacement. And usually we want to wait until we go through that. All right. So let's take a look at general features of the bone. It's probably easiest to see by taking a look at the actual bone matter itself, right? Again, even long bones are a combination of dense compact on the outside. Internally, we have the spongy bone. The spongy bone region are where we're going to see, again, the red bone marrow that will eventually become red blood cells and white blood cells. But if it was all just spongy bone, number one, it'd be much weaker. And number two, spongy bone is, right, spiky, right? It's not smooth. It will damage our own internal, right, structures like the tendons it's supposed to connect to, right? So we don't want it to be just spongy bone. We have this outer layer of dense compact on all of our bones. Now, what else do we see? The ends right here, this is a proximal epiphysis. This out here is further away from the torso. So this is our knee area. This is our distal epiphysis, right? Now, the periosteum right here is the external area of the bone matter. Now, most of us are not going to touch any cadaver bone, right? It'd be kind of gross to do that, but we've eaten, right, some of this, right? So when we eat like a drumstick, when you look at the actual drumstick itself, that's a tibia, right? So once you remove the meat, right, and you look at the bone itself, it's shiny, right? It's shiny because there's this connective tissue over it. That connective tissue is called the periosteum, right? Now, in the internal aspect of the periosteum, we see stem cells that will turn into bone-forming cells called osteoblasts, right? So the periosteum itself is this kind of connective tissue, fibrous connective tissue that lays on the outside, right, of the bone matter, but can migrate inwards though, especially some of the cells. So we have the periosteum. Whoops. The periosteum covers a bone, is that kind of gives that bone that we see that glossy look to it, right? Um, Covers bone except where there is articular cartilage. The outer layer is made out of collagen. This is a big one right here. The outer layer contains, right? Outer fibers is continuous with the tendons that attach the muscle to the bone. So that's the stuff that I'd ask you to know for the test, right? In other words, why are the tendons so strong that we never hear people, ripping the muscle from the bone at the tendon? Usually, when you rip your Achilles tendon, what happens is where the meat of the muscle turns into the tendon. All right, that's a weak point. You don't rip it apart from the heel, right? Why? Is because when the muscle goes into the tendon and the tendon turns, right, and inserts onto the bone itself, the tendon actually becomes the periosteum. So that periosteum is continuous with the tendon, making it one continuous unit where the tendon becomes part of the bone itself, right? So in order to actually rip the tendon off the bone, you actually have to rip the periosteum off. That requires a lot of stress. It can happen, but usually it happens under some kind of violent conditions. All right, football players when they're getting tackled and they can't resist that actual pressure of three, four people tackling at their knee at one time. That can happen, right? Or some kind of violent car accident force, right? That can cause the actual tendon to rip away at where it attaches to the bone. Um, to make that connection even stronger, again, right? The tendon becomes part of the bone, right? Because it becomes part of the periosteum. Now, to make it even stronger connection, we have something called Sharpie's fibers, where we basically have a tack, right? So we have the tendon turning into the periosteum. That's strong enough. And then what we're going to do is at the region where the tendon becomes a periosteum, right? We're going to use a screw and screw that tendon into the bone matter. That's a Sharpie's fiber, right? What does it allow us to do? Really reinforce that connection. So then, right, number one, this is strong enough by itself, right? Now we're going to add these Sharpie fibers where we have basically screws we connect. So then when the right tendon becomes a periosteum of the bone, right, we screw it in place. As we screw it in place, you reinforce that connection between tendon and bone that allows us to have super strong attachment and continuity from muscle to tendon to bone. So the weak point is actually the muscles themselves. So when you rip muscle, usually it's at the belly, the meat of the muscle that rips. The periosteum also has an inner layer that we mentioned, right? Contains stem cells that will turn into osteoblasts. So that allows us to heal from fractures as well, right? So the periosteum is outer layer that's continuous with the tendon. At the junction where the tendon becomes a periosteum, we have Sharpie's fibers, which allow us to connect that connect now reinforce that connection by basically drilling, right, these fibers in place. So then the tendon is really fixed there. The inner layer contains, right, stem cells that will become osteoblasts so we can reinforce and make new bone if we have to. Right. Endosteum, thin layer of reticular connective tissue, has cells that dissolve osseous tissue and others that deposit it. We'll talk about these cells coming up, right? The epiphyseal growth plate, right? Area of hyaline cartilage that separates the marrow spaces of the epiphysis and diaphysis. Basically, the epiphyseal growth plate is going to be the area that is going to separate the ends from the shaft, all right, the middle part. So for people who have not fully matured, so if you have a 9-year-old, right, 9-year-old boy that has yet to undergo puberty, what happened? That epiphyseal growth plate, right, is pretty big. And that epiphyseal growth plate will determine how how tall that child will get, right? So if you have a very large epiphyseal growth plate and the child is already pretty tall, right? Their ability to get much taller in adolescence, right, is much greater than you have a child that's already short and have a very narrow epiphyseal growth plate, right? Growth plate is where we allow us the bones, the long bones, to grow in length. And the weird thing is this, if you've ever seen a teenager before, right, especially boys, right, what happens? When they hit the growth spurt, they get really tall and really thin at first. Why? It's because of the bones. The bones themselves are going to grow in length, right? Really quickly. As they grow in length, they're going to get much taller and they're going to look very gangly. And with time, right, those really tall, long bones, right, are also really skinny. With time, we reinforce the bones and the bones actually get thicker, right? As they get thicker, now they look a little bit more, I would say massive. They look like a little bit more adult-like, right? As they start to fill in, right? Now, again, the epiphyseal plate is this area of hyaline cartilage. And we're going to see at puberty, right, cartilage growth at these plates will allow further bone growth later on, right? It allows us to grow in length. Again, right, here's that marrow cavity. The red bone marrow is here. The yellow bone marrow is here. Yellow bone marrow is just fat, by the way, right? Again, I use that example of cows, right? How people eat the yellow marrow in cows. and use it almost as like a delicacy. All right. Uh, what other kind of bones? So we talked about long bones. I'm going to talk about some of these flat bones. With flat bones, we have this external layer that's dense, compact, right? Strong, thick. The problem is it's also heavy, right? So if you just had dense, compact bone throughout the length of your skull will be two, three times as heavy as it is right now. Now, what else do we do to lighten the actual weight of the skull then? Number one, we have sinuses. Number two, right, in bones that don't have sinuses, right, they have this middle area that's spongy, right? Then the inner area that's compact as well. Remember, spongy bone right here has regions that kind of, it's not very smooth, it's rough. They have bone tissue, right, that kind of moves inwards, right? So it can damage our own brain if it was just this kind of spongy bone. So we want protection from the own bone. So on the innermost layer, we also have dense compact bone. Again, a sandwich. So when we talk about flat bones, especially the skull here, right, is a sandwich where we have dense compact on the outside. This middle area is spongy, dense compact on the inside. All right. Then we have a lot of strength, right? Able the actual weight a little bit. Right. Now comes the actual bone forming cells, right? Bone is a connective tissue that consists of cells, fibers, and ground substance. Remember when we wrote that out, right? So the cells that are important here, right, are words that, have that all start with the root osteo, osteogenic cells, osteoblasts, osteocytes, osteoclasts, right? We also wrote that whenever you see the word B, these blast cells build, right? So again, the osteogenic cells, these are the cells these are the stem cells, right? Stem cells found in the endosteum, in the periosteum, right? These are the cells that migrate, so then to surround the blood vessel, we call the central canal. As they migrate and surround it, right, they turn into osteoblasts. These osteoblasts then start forming bone matter surrounding that central canal region. All right, the central canal, let me see if there's a good picture of this. Right, this is a central canal right here. Right, so central canal region, that's where the blood vessel is laid. Then you have cells that migrate so that they can surround the central canal. As they surround the central canal, they tap into the blood source here by a process, right? So then they can receive nutrients. So they can receive enough amino acids to produce collagen. So they can produce, right, proteoglycans, all right? So they can produce calcium phosphate, right? But then there's a limit, right? If you're too far away, you get to a point where you're so far from the blood source that you can't receive any more nutrients. So there's a width at which we can only get to, right? So we want to get more wide, we actually lay another blood vessel here. If we would lay another blood vessel here, then we have another osteon, another tree ring that we can add to it, right? So again, that picture kind of shows us how we lay down that bone matter, right? The osteoblast is going to reside surrounding that central canal. Then they're going to produce collagen because they're tapped into the blood source, right? Now, the collagen and the proteoglycans, they're pretty strong, but not hard enough. So you need to put calcium phosphate on it. Remember, your body weight, right? The bones have to support your entire body weight. So it has to not just be kind of strong, it's got to be very dense, very rigid, and strong, right? Stress and fractures stimulate osteogenic cells to multiply more rapidly and increases the number of osteocytes. I'm just going to highlight this. I don't know why that's not highlighted. Right here, right? And I'll right? And I'll kind of, repost this. Again, this kind of makes sense, right? Stress and fractures stimulate osteogenic cells to multiply more rapidly, increasing the number of osteocytes to reinforce and rebuild bones, right? This is the reason why, if you've ever watched old movies, right? Old movies, you'd have somebody have, they break the leg and then they put them in what we call traction, right? They put them in like a cast and then they'll kind of, and it's painful because they'll kind of separate that area where there's a little bit of a fracture, right? Putting a little bit of stress in the area where there's a fracture, right? We call that an external stress or external traction. Nowadays, we don't do it that way, right? We put rods in there and we have internal traction instead, right? It provides that added stress, right? Provides increased activity of that bone matter so then you can repair faster, right? Now, we're going to see stress really increases bone formation, right? The opposite is also true. Lack of stress will cause the bones to atrophy, will cause bone to degenerate. That's one of the problems we see with people that are astronauts, right? People that go up in space and they're in space for months at a time. You ever wonder why you always see people go, the astronauts, when they leave, it's a huge press conference, right? The media's all there, everybody's there, right? How many times have you seen them after like 6, 7 months, sometimes a year? How many times have you seen them walk off the airplane? Walk off, right? They don't, right? Because by the time they've been up there that long, no matter what they try to do to decrease the bone loss, there's going to be tremendous bone loss. Not only will there be tremendous bone loss, there'll be muscle wasting. So they will have a hard time just walking down any stairs. So usually they'll actually gonna have, and to prevent any kind of damage by falls, they'll actually have them in wheelchairs as they come out. Just because even being in gravity after a year, right, produces a lot of stress on the heart. So you don't want your astronaut that you just, put so much emphasis on to try to walk down and fall and break a leg. That's not good, right? So you never really see them leave, especially after a long time up in space, right? Again, stress increases bone building, right? Lack of stress, right, increases bone resolving, right? Secrete osteocalcin, thought to be structural protein of bone, right? Stimulates insulin secretion in pancreas, increase in insulin sensitivity in adipocytes, limits growth of the adipose tissue. Basically, that again kind of makes sense, right? When we're building something, we always want your body to be accumulating. So insulin is going to be secreted so then we can get more nutrients into the cells because you're building, right? Osteocytes. So the osteoblasts are the name of the cells as they surround the central canal and start laying bone. Osteocytes are the name of these osteoblasts once we've already made that bone tissue. So these right here, these are all osteocytes because they already have made the bone matrix already, right? So osteoblast would be what happens if you just started forming the bone. We see these cells, but you don't see the hardness that we see in bone yet, right? That's osteoblast. Once you start seeing mature bone and these cells become kind of surrounded by its own matrix, we call them osteocytes. So osteocytes come from osteoblasts. Osteoblasts that have completely surrounded themselves by all of the matrix they've made. They already put collagen, surround themselves, right, with collagen. They surrounded themselves with all these glycosaminoglycans. Then they add calcium phosphate to it. Now they're fully surrounded by its own matrix they built. Now we call them osteocytes, right? Again, bone is very rigid, very tough, can be very sharp, right? You guys have felt what the actual bone is in real bone. It's different from the plastic bone that we have, right? Some of the models that we have. In real bone, if you really touch it, number one is doesn't weigh as much. Number two, it's pretty sharp, right? You wouldn't want something really fragile to rest right on that bone tissue, right? Cells also need to be protected by its own matrix. So they rest in pockets we call lacunae, right? These are tiny cavities where osteocytes resides. Now, the osteocytes are connected to each other and connected to the central blood vessel by canaliculi, right? The canaliculi are little connections that allows us to link one cell with another cell, and then one cell to another cell, and that cell will be linked to a blood vessel, all right? Within the canaliculi, you have processes that allows us to connect cell to cell, right? Some osteocytes reabsorb bone matrix while others deposit it. They contribute to homeostatic mechanism of bone density and calcium and phosphate ion type of balance. When stressed, right, we produce biochemical signals that regulates bone remodeling. Right. So we're talking about not when you're stressed. We're talking about when the bone is stressed, right? When the bone is stressed, we always deposit, right? Now, osteocytes come from osteoblasts. Osteoblasts come from osteogenic stem cells, right? So there's a real linkage, right? Those osteogenic stem cells, they're going to turn into osteoblasts. The osteoblast is going to build all this bone matter, turning into osteocyte, right? Osteoclasts are completely different. Osteoclasts come from immune cells that we find in our bone marrow. So they're a different classification of cells altogether, right? These are the bone dissolving cells found on the bone surface. Osteoclasts develop from the same bone marrow stem cells that gives rise to white blood cells, right? So they come from a different origin than the bone cells, the osteoblasts. They're much larger, and the main job we're going to see is to dissolve bone, right? There's always that balance between making bone and then destroying bone or reabsorbing it, right? Now, your body only cares about how much calcium we have in our bloodstream, right? So what happens? If we don't get enough calcium in our bloodstream, we will demolish more bone rather than build it. Because remember, right? Your calcium phosphate right there, right? Well, your bone is a bank for calcium phosphate. So if you don't get enough every day, you start destroying more and more bone. Now, the good news is, for women and men, we're protected by our hormones, right? Estrogen, testosterone, until you hit menopause, right? Now, when we look at these osteoclasts, right, they become slightly more active post-menopausally. So you'll have more bone destruction post-menopausally. So you need to really, really take care of your diet at that point, right? So the bone cells, especially the right osteoclasts, know what they do. I'm not going to ask you to know right which side, right? They, how they do it, how they reabsorb bone. Just know that their main purpose is in bone resorption, right? The rest of this kind of is a little bit too much physiology for our class. That's why it's not highlighted, right? Now let's talk about the matrix material that we kind of talked about. When we talk about connective tissue is always going to be a combination of cells that make it, fibers, and ground substance. The fibers and the ground substance form the matrix then, right? Again, right? For bone, we have an organic and inorganic matrix, right? The organic matrix is synthesized by the osteoblast and is basically collagen and ground substance. The ground substance are the glycosaminoglycans, proteoglycans, things like that, right? So you have collagen and glycosaminoglycans that form a ground substance, right? Now, again, what does the organic matter do? It allows our bones to have slight flexibility. So when you fall, right, you can imagine you're walking or you're running, it's in the middle of winter and you fall, right? When you're your age, you're probably looking around if anybody saw you fall, right? Like, oh God, I hope nobody saw me, right? You fall, there's no other issue. You're not even worried about any kind of fractures, right? You get to be my age and a little bit older, okay, a little bit older, like 70, right? You're not worried about if somebody sees you. You're hoping somebody sees you, right? Because when you fall at that age, right, your bone doesn't have as much hardness and the collagen even is slightly different. It doesn't have the same flexibility. So when you fall, it breaks instead of bends, right? It sucks, right? So that organic matter is collagen, right, is important because it allows for the flexibility of the bone when we do fall, right? When we put stress on the bone, when you're doing squats, right? You don't even have to do weight when you're doing squat. But if you're doing any kind of weight when you're doing squats, right, that's going to even add more stress to your femur. And your femur is going to be more flexible or has to be more flexible, right? So then you don't break it. So this organic component allows us to have flexibility. The inorganic allows us to have that toughness, the rigidity, right? Again, 85% of it is hydroxyapatite, which is calcium phosphate. 10% is calcium carbonate. So if you take a look, 95% of it is calcium, right? Calcium is incredibly important, but your body only worries about your day-to-day calcium, right? So you need to eat it every day, whether it's dairy and vitamin D, or you have some other kind of pill you're taking, right? That calcium is going to be important for your blood in terms of all of the different steps in causing a blood clot to form. Almost every step requires calcium. We're going to see that for a muscle to contract, you need calcium to be released, right? For your heart to work, you need calcium to be released, right? For your brain and your spinal cord to function, you need calcium to be released, right? So all this stuff requires calcium, and the only place you can get it from is your bloodstream. So if your blood calcium's low, right, the calcium goes into all these other areas first. Then, if there's any more left, then it'll deposit it. If there is not enough, it'll break down more bone matter. So there's always that balance, right? You need to have enough of it for your body to use because you have all these mechanisms that requires calcium every day. So if you don't get enough every day in a diet, you start demolishing more and more bone every day and not depositing it, right? Again, bone is a composite of a ceramic and a polymer, right? They got really weird talking about this, right? So just understand for now that what collagen does, right? That what hydroxyapatite is, right? They use that fancy word because they want you to get used to using fancy words, right? So hydroxyapatite, real fancy, right? It's just calcium phosphate, right? So that hydroxyapatite is calcium phosphate. Know that it's calcium phosphate, right? That the toughness that we think of bone, right, is a combination of them with the flexibility of collagen and the denseness, the toughness, the rigidity of that calcium phosphate together, right? Right. Now we look at spongy bone. Spongy bone, again, spongy-like appearance. This is all type of, on the outside here, all dense compact bone. This spongy bone on the inside right here. You see how it looks like it has a little piece of that sticks inwards like this? It looks like little needles coming in, right? So what happens is like spongy bone is sharp. So you don't want this sharp area facing, right? Your heart facing your brain. So in those areas where we have flat bones, right, you always have an inner layer that's also dense compact, right? Coming back to what we were talking about before. So this is spongy bone right here. You see how much open space is found in spongy bone, right? Enough space to stem cells, especially the end of the long bones. The end of the long bones are filled with these spicules of spongy bone, allowing us to have a lot of bone marrow, red bone marrow there, right? So the red bone marrow, these are the bone marrows that stem cells are going to be living in. Those stem cells are going to turn into red blood cells. They're going to turn into the numerous type of white blood cells. Those stem cells can also turn into platelets. So these stem cells can be just about any type of, right, blood forming cell. So it makes it really important, right? Spongy bone has very few osteons and no central canal. All the osteocytes are close to the bone marrow, right? And the trabecula develops along bone's line of stress, allows us to have a lot of strength with minimal weight, right? Now with the trabecula, I'm gonna see if there's a good picture of it, right? Right? I don't know if you can see this here, but if you take a look right here, it looks like all these are kind of facing the same direction, these spicules, right? See that? It's not going up, right? It's going laterally. See that? And the neck right here, right? It allows us to bring stress from the head through the neck into the shaft. You have to look really carefully, I know, right? If I can find a better picture, I'll show it to you, right? Right. So these are the areas in adults where you actually see red bone marrow, right? Obviously, if you're a bone marrow or a donor, we're not drilling into your skull, right? So we're not drilling in your chest, all right? Because last thing we're going to do is penetrate and cause you to, I don't know, have some kind of pneumothorax or any kind of, right, or collapsed lung, right? So usually, where do we harvest our, right, bone marrow? In the ilium. So we actually have to take a kind of a device that drills into the ilium, drill through the hard, dense, compact bone of the ilium. Then, right, take a big giant needle to harvest the cells there, right? Doesn't feel good, right? So red bone marrow right here is myeloid, right? It's kind of crazy, right? In nearly every bone in a child, all right? It is also considered hemopoietic tissue. Hemopoiesis is blood cell formation, right? So it can be red blood cells, right? We call it erythropoiesis, or white blood cells, right? So hemopoietic means that you're forming some kind of white blood cell or red blood cell, right? And adults found usually right down the middle of your body. That's it, right? Skull, vertebrae, ribs, sternum, pelvic girdle, right? And all right, proximal heads of the humerus and femur, right? Most of the red marrow that we see as babies turn into yellow marrow that we see in adults, right? Bone development or osteogenesis. And I'm going to highlight these two right here, right? There's intramembranous and endochondral, right? Only one I really want you to know is endochondral, all right? And the reason why is simple. With intramembranous ossification, we're talking about really early on in gestation, first trimester, right? You're just at first a ball of cells that have now coalesced to form almost what looks like a very, 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 very small baby, right? We don't even call you a small baby, like a very small fetus, right? What happens is we have these cells that migrate to your skull, but only certain parts of the skull, right? Maybe part of the parietal bone, part of the mandible. And those cells immediately turn into osteoblasts and start forming bone. That's intramembranous ossification. Number one, it's rare, right? Most of your bones are not formed this way. Number two, right, you have these stem cells turn right into osteoblasts and depositing bone, right? Now, when we talk about most of our bone is formed by endochondral ossification, where the bone itself is made out of cartilage, right? Within the first trimester, first, right, every single bone of your long bones are all made out of cartilage. Then, at about the start of the second trimester, right, there's an opening in the cartilage right in the middle, right? And a blood vessel penetrates through, new bone forming cells go in there, and we slowly build bone, right? And replace the cartilage with bone from the middle of these bones up and down, right? As we basically replace that cartilage with bone now, right? We have it from the shaft down, shaft up, right? Then in the ends, right, we have another blood vessel penetrate. And now at the ends, we replace the ends with bone from the inside outwards, right? So from the middle up and from the inside of the shaft of the head, right, or out, right? What happens? There's an area where we don't replace with bone. That's going to be our epiphyseal growth plate. So that epiphyseal growth plate that we always think about, right? That we hear about all the time that allows us to grow, that epiphyseal growth plate could be one of the oldest cells that we have in our whole body. Those are cartilaginous cells. that was found early on in gestation in the first trimester, right? The area of bone that we didn't, that area of cartilage that we didn't replace, all right, at the second trimester. That's an epiphyseal growth plate. Now, eventually, it will get replaced. The second area where we never replace is at the very ends. Remember, right? At first, your whole bone is cartilage, even the ends, right? So what we're going to see is we never replace the very, very, very end where it makes contact with other bones, right? That cartilage becomes articular cartilage, right? So your articular cartilage could be one of the oldest cells that we have in our body. It's been with us since the first trimester of life, right? That's why we have such a hard time re-stimulating cartilage growth, no matter how much money we put into research. Right, so here just showing you fetal skeleton at 12 weeks, making sure that we know it's almost all, right, cartilage. Right, almost done. We'll talk about some diseases like dwarfism. We're not going to talk about these fractures, right? And we'll talk about osteoporosis, and that's it. So let's continue, right? Dwarfism. What is dwarfism? Right? In terms of dwarfism, we have two main forms, right? We have achondroplastic dwarf and pituitary dwarf, right? In pituitary dwarfism, lack of growth hormone, normal proportions with short stature. All right. In other words, when you look at their long bones, they're proportionally short. These are your tiny, tiny people, right? You're 3 feet tall, right? They look like just miniature versions of people, right? Just much, much, much shorter, right? Now, we compare that to achondroplastic dwarfs. Dwarfism, usually the problem is only in the long bones. So if you look at the torso right here of this little person, and then we compare it to this woman right here, right? It's not much shorter. But when we compare the arm length of this little person to the arm length of this woman, right? It is much shorter. We compare the leg length, the finger and toe length is also shorter. So with achondroplastic dwarfism, it is the long bones that are severely affected right here. Normal torso, but short, short limbs. Failure of cartilage growth in the metaphysis, right? Spontaneous mutation produces a mutant dominant allele, right? In other words, with a mutant dominant allele, right? Dominant trait means that you need only one copy. With all these traits, you need to inherit one copy from mom, one copy from dad. The best example of this is with sickle cell anemia, right? That's where we start seeing the Punnett squares, right? With sickle cell anemia, if you have one parent with a trait, another parent with a trait, without the disease, they just have the trait, there's a 25% chance of having a baby with the full disease, right? Now, with this type of disease, right, where it's dominant, all you need is one instance of a bad gene, right? Whereas in sickle cell, you need to inherit two of the genes that are bad, right? Sickle cell gene from dad, sickle cell gene from mom, right? Now you're what we call homozygous for it. You have two of that recessive trait, right? Now you're going to have the full disease. Well, this one is worse, right? Because all you need to do is inherit one of the disease genes from one of the parents. So one of your parents is normal height. The other parent might be normal height, but they have within it the gene for achondroplastic dwarfism, right? So if they give you the gene for achondroplastic dwarfism, you will have the disease. It doesn't matter what the other parent gives you. They could have given you the healthy gene. Doesn't matter, right? You will still have it, right? The problem becomes, and anybody ever watch Little People Big World, right? With Little People Big World, right? The dad has a different kind of dwarfism. The mom has achondroplasia, right? Now, they're always worried about when you get two of the bad genes. So if you have two little people getting married, they have to go through incredible amounts of genetic testing. Why? Simple, right? Well, in order to have it, they have one bad gene, right? That's why they have achondroplastic dwarfism. The other, right, partner has one bad gene. So there's a chance, a 50% chance of having a child with two bad genes, right? They inherit the bad gene from mom and inherit the bad gene from dad, right? When you have two of the bad genes for achondroplasia, it is an dominant, and it is one of those diseases where, all right, 95% of the time they die in utero. The other 5% of the time, right, they die shortly after birth, right? It is a genetic lethal disease, right? So it's not one of those where you want to, right, kind of carry on that pregnancy, right? Because there's just no hope of the baby ever living. So they have to be very careful. They might even want to do in vitro fertilization so then we can pinpoint which ones are the cells that we can kind of harvest, right? It's that deadly when you inherit both bad genes from both parents, right? And it also makes sense that the parents are going to have one good gene and one bad gene because if they both have, the bad genes, they would have never survived, right? So this is a dominant allele, meaning that dominant trait disease, autosomal dominant. That means all you need is just one instance of it. That's it, right? Some diseases are like this, right? Some of them that you might have heard of. Anybody's ever heard of Huntington disease? Huntington disease is probably the worst combination of what you see in Alzheimer's and what you see in Parkinson's, right? It's a movement disorder and it is a memory, right? Ability disorder, right? So what happens with it is usually you have one bad gene that's given, right? If you have two of the bad genes, you die really early on, right? So it's almost always genetic lethal. The worst part with Huntington's is that the first generation of the person with the disease usually don't find out they have the disease until they express symptoms when they're in their 40s and 50s. In other words, when they already had kids, right? So then they might have already passed on that disease to their kids, right? And their kids might have already had kids by then, right? And now you have what's called, right? You have this process we call amplification, where, right, as you give that disease trait to other generations, they express the disease earlier and earlier and earlier, right? And then by the time you have by the third, fourth generation, right, kids start to really get the symptoms where they have Alzheimer's like symptoms, where they have movement disorder by the time they get in their teens, early teens, right? And then a whole just kind of right family history ends right there, right? We do see that with Huntington's. Right. Again, with achondroplasia, it's nothing quite as bad, right? But it's one of those where you can have a normal life with achondroplasia, right? You guys have seen that in Little People Big World, right? They have a nice big farm, right? The weird thing is the kids are all just about healthy. All right, out of the four kids, only one have achondroplasia, right? So again, right, with achondroplasia, there's a 50-50% chance of having kids with achondroplasia, right? They beat the odds. So they should have two, maybe three kids with achondroplasia, right? But just like when you toss your coin up, right? You never are going to get 50% if it's just a very short number of times you toss it up, right? Last thing I want to talk about, osteoporosis. Why? Simple, all right? We might all get it, right? Osteoporosis, the most common bone disease. Severe loss of bone density leading to fractures, leading to lots and lots and lots and lots of joint issues as well, right? Bones lose mass and become brittle due to loss of organic matrix and minerals, right? Affects spongy bone the most since it's the most metabolic active, allows you to become subject to pathological fractures of the hip, wrist, and vertebral column. By the way, right, do you guys know the actual percentages of people who die with fractures, right? Leg fractures, hip fractures, when they hit elderly age, right? So let's say you have a grandparent that's 75, 80 years old, right? And they fracture their femur, right? Usually when say they fractured the hip, usually it's the neck of the femur they fracture, right? So if it's any kind of fracture of the leg, what are the chances of that person dying in the next year? 50%. 50% of the people that fractured their leg are going to die within the first year, right? Only about 15 to 20% ever attain their normal pre-fracture, right, kind of daily activity, right? That's it. So you have to protect the grandparent. They have to be careful. I know they're pretty damn stubborn, right? But you got to make sure, right, their stubbornness doesn't affect them and affect you guys, right? Because you don't want your grandparents to live with you, right? So yeah, that can happen. So, that, I mean, the weird thing is this, there's this huge kind of, mortality rate until you hit about 80, 85, 90 years old, right? Then it kind of normalizes because there's huge amount of mortality in all those people that are 85, 90 years old, right? That sounds terrible, but yeah, right? You don't need to fracture a hip to die in the next year, in other words, right? Now, what else do we see? Kyphosis, widow's hump, the deformity of the spine due to vertebral bone loss, right? We'll talk about it in the next chapter, but there's three types of deviation of your vertebrae. All right. So your vertebrae should be right down the middle. You should have an S-shaped vertebrae, right? Should be nice and right down the middle, your vertebral column. So what happens if there's a lateral deviation? So instead of right down the middle, it kind of moves to the side a little bit. We call it scoliosis, right? Now with this is a anterior, right? So then your humpback, right? Think of, right, the humpback of Notre Dame, right? Or some people, right, that they're kind of humped over like this, right? This humpback doesn't just affect their back, right? It also affects their lung function. Think about how hard it is to breathe in if you're completely hunched over like this, right? So it affects their pulmonary circulation as well as some of these, you know, kind of pain symptoms, right? Posture issues. You can imagine the amount of arthritis, right? If your back is like this, humped over, right? How many slip discs you might have from this and pinched nerves, right? It's not good, right? So back in the old days, we used to give people a lot of estrogen. So anybody pre-2000. If you have grandparents then, all right, once you hit menopause, we give them hormone replacement therapy, right? Predominantly estrogen and a little bit of progesterone, right? It's perfect. Why? Because it replaces what you normally had, right? Premenopausal estrogen, progesterone really, really is protecting your not just your bones, but your heart and your brain. Have you guys ever heard of many people, many women that have had MIs, heart attacks, right, in their 30s, 40s? Not really, right? Most of the time you hear the horror stories of women that have had heart attacks in their 20s and 30s, right? But you don't know anybody. How many guys have you heard about getting heart attacks in their 20s and 30s, right? It's a lot higher in their 20s and 30s. The reason why women don't usually have heart attacks in their 20s and 30s is because of the effects of estrogen and progesterone. So we knew that number one, right? Women were coming in postmenopausally, right? We're worried about their bones, we're worried about their cardiovascular health, right? So we give people this hormone replacement therapy immediately. And what they found out was in the early 2000s, they came up with this study which showed, or supposedly showed, that the hormone replacement therapy, right, caused more cardiovascular incidents and was not very, and it kind of linked, there's a little link to cancers, right? Cervical cancers, uterine cancers, right? Some breast cancers even, right? What they found out now is that that study was pretty flawed. So now but for a whole generation, right? Nobody was on hormone replacement therapy. Even now, if you go actually probably go talk to your parents about hormone replacement, they get really worried, right? Because their doctors back then told them that they can't prescribe it because of the risk of cancers, right? We found out, just like a lot, right, of this is that with more knowledge, we found out that the correlation between cancer and hormone replacement wasn't that great. And that some women, right, whether due to how bad some of these hot flashes get, right? People will get such massive hot flashes where they will start to sweat uncontrollably, right? Then they get really cold and then they sweat again, right? And sometimes they wake up in the middle of the night numerous times because of this, right? That they have a hard time living with it. They're willing to risk whatever kind of, right, risk that they can see, right? Just so they can live day to day. So we're seeing a lot more doctors willing to prescribe and starting to prescribe more hormone replacement, right? Now, when we're worried about hormone replacement, estrogen right here in women, right, is going to be very protective. The problem was for a whole generation of women, we didn't have estrogen to give them. So we started seeing, all right, we started having a need of medications, right? So have you ever heard of some of these medications, Fosamax, Actonel, right? They work really well, right? But they're not protective of the heart. They don't do any of that. What they do is actually pretty cool, right? They inhibit the functions of your osteoclast, right? So then you don't have as much bone breaking down. If you don't have as much bone breaking down, you'll hopefully deposit more, or at least stem, right? Decrease the amount of bone loss from bone breaking down, right? Now, what else do we see, right? We tell people that are postmenopausal, right? Again, it's one of those thin white women, right? Postmenopausally are more commonly affected with osteoporosis, right? By age 70, average loss is 30% of bone mass, right? Now, a couple things will help decrease the odds. Number one, weight bearing exercises. And this is one of the rare times where being slightly overweight, slightly plump, right, actually is helpful, right? Reason why is because, again, the heavier you are, the more weight bearing exercise you do, right? What do we say? Stress adds bones. You add more stress to the bone, you have more bone. So you've heard of like the old days when people are like, oh, you're not heavy, you're just thick boned, right? It's kind of true, right? The heavier you are, the thicker the bone you have, right? So yeah, that's kind of true, right? Now, it's also true that swimming is great for you, right? Doing any non-weight bearing exercise is great for your joints. The problem is you need to balance it with some kind of weightlifting, right? The weightlifting, the weight bearing exercises is good not just for the muscles, but with the bone deposition. By the way, there's one other class of people that actually, and I highlight this for a reason, that actually has increases odds of having osteoporosis, even as adults and not elderly. And that's young female athletes, right? The reason why is simple. Remember, estrogen is very, very protective, right? What we'll notice is that, right, these women that are in the Olympics, right? They're exercising for hours and hours at a time. Their body fat content is so low, they don't have enough body fat to produce enough estrogen, right? And then they don't have normal, right, menstrual cycles then. So what happens, right? Well, that menstrual cycle that has now decreased and not normal anymore is a sign that there's an estrogen progesterone issue, right? In order to actually have menses, you need to ovulate, and that requires estrogen and progesterone. So by missing, right, the actual menstrual cycle, we have an issue with estrogen and progesterone. So women that are really thin, women who are athletes and have very low body fat, right? Even if they're 20 years old, they're at increased risk of, right, osteoporosis, right? It's kind of crazy, but also that's also the reason why after each Olympic game, after each World Cup, you hear of a women's World Cup, you hear of a lot of women athletes retire, right? They retire and then maybe 4 years later, they unretire, right? And come back, right? They usually retire for a reason. They want to have kids, they want to start a family, right? And in order to do that, you're not going to be, all right? You can't be working out 10 hours a day, right? You need to relax. And it's kind of weird, but you got to actually gain body fat, right? Once you do, then you can have normal menstrual flow, which means you're ovulating. So when you don't have normal menses, it's a sign that you're not ovulating. You can't have kids at that point, right? So they actually have to gain weight in this process. And you guys have heard of not just this, but horror stories of people, of women that are, right, that's got eating disorders, right? And they're so thin that they don't have any body fat. What is one thing that happens in response, right? They start missing their menstrual flow as a result. Why? It's because of the amount of estrogen that's produced, right? You need a certain body fat to have enough estrogen produced so that you have normal menstrual flow. All right, that's it with this chapter. Let's take a break.